I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello, and welcome to the sixth installment of the PRS Journal Club. My name is Raj Sawh-Martinez, and I'm joined by my fellow resident ambassadors, Amanda Silva and Sammy, Sinno. This month, we are privileged to be joined by Dr. Rohrich, legendary founding chairman of the Department of Plastic Surgery at UT Southwestern and our editor-in-chief of the acclaimed Plastic and Reconstructive Surgery Journal. Dr. Rohrich, thank you so much for taking time out of your busy schedule to join us for this 6-month anniversary edition of the PRS Journal Club.
It's great to be here.
In this section, we'll be discussing a study out of the University of Michigan by authors Mahmoudi, Yuan, Lark, Aliu, and senior author Dr. Kevin Chung. The study is titled Medicare Spending, an Evidence-Based Approach in Surgical Treatment of Thumb Carpometacarpal Joint Arthritis, 2001 to 2010. Clinical trials and meta-analyses have not demonstrated a statistically significant difference in the outcomes among the different surgical treatments of thumb CMC arthritis. In this study, the authors sought to evaluate the potential differences in cost among 4 main treatment options. 1, trapeziectomy with ligament reconstruction and tendon interposition, or LRTI. 2, simple complete trapeziectomy. 3, CMC arthrodesis. And 4, prosthetic CMC arthroplasty. Owing to a small number of patients, the author ended up combining both the CMC arthrodesis and the total joint replacement patients, creating 3 comparison groups. The research team examined a random sampling of 5% of Medicare claims data between 2001 and 2010, totaling about 3,500 patients after their exclusion criteria were satisfied. They sought to evaluate 3 main things. 1, the national trends in reimbursement. 2, factors that are associated with direct and total spending. And 3, examine variations in spending based on surgeons' reimbursement fees and the location of the surgery. The authors hypothesized that trapeziectomy with LRTI would incur the greatest cost to Medicare. The main findings of this data demonstrated that the majority, about 89% of those sampled, received trapeziectomy with LRTI, totaling an average of approximately $2,500 and out-of-pocket expense of $436. Complete trapeziectomy alone was the least expensive procedure and also the least performed procedure. Only 5% of the study patients had this procedure, with a total cost of about $1,270 with an out-of-pocket cost of $236. The total cost difference here was about $1,200. Additionally, they found that for all 3 surgical procedure groups, the cost was substantially higher when carried out in a hospital outpatient setting compared to an ambulatory surgical center. These results here are fairly impressive. The trapeziectomy with LRTI, those hospital outpatient setting costs average a total of about $4,000 compared to about $1,800 when the same thing was performed at an ambulatory surgical center. There are other various important data points in their analysis, but really the biggest take-home point made by the authors is that if we extrapolate their data, they estimate that Medicare could potentially save $74 million annually if complete trapeziectomy was a procedure of choice. This is a really interesting study and sort of the first time we've really looked at something where clinically the outcomes have been comparable, and now we're really making a strong statement about cost. Dr. Rohrich, as a former and well-trained hand surgeon, what are your thoughts? Did you do trapeziectomy and LRTIs?
Well, once a hand surgeon, always a hand surgeon. So first of all, I applaud the Michigan group, Go Blue, for this very interesting study. And we're seeing more and more cost-effectiveness studies, in the journal, not only in hand, but in breast reconstruction. The only thing I would say is that, some of them state the obvious, outpatient ambulatory centers versus outpatients in hospitals. Obviously, that's more cost-effective. But I would say that you really can't always compare a simple complete trapeziectomy to LRTI. In most cases, I would still prefer to do an LRTI. In most cases, they're not totally comparable to a complete trapeziectomy. I can see why people don't do that because, I don't think the results are, and of course, this was not a results comparison. This was a cost comparison study. So personally, I think that's one of the limitations is that are they truly equivalent types of results? I'm not so sure of that. So that would be one thing. And the other point is, there are so many other outstanding factors here, which contribute to the cost. I mean, obviously, the CPT coding for LRTI is higher, and so you get paid more. And so, obviously, that's one of the other reasons where they're probably being done more frequently. But I think, it's an interesting study. It's a stepping stone that if we're going to be truly developing guidelines for care, do they need to be 100% cost-based? I'm not so sure that if the cost-based that always, does that extrapolate to best care? I don't know.
Right.
What do you all think?
I mean, I agree. I think obviously any study that Dr. Chung is involved in, is going to be well executed and on point. But I think that's the question. I see it in our own hospital, where the hospital is paying a lot of attention to comparing procedures, and breast reconstruction, as you mentioned, comes to mind. And they'll say, well, why can surgeon X do a breast reconstruction for X amount of dollars and surgeon Y for Y amount of dollars, and it's different, and why is that? And I think it's very challenging when you start comparing different procedures and different techniques and patient outcomes that aren't going to be the same. We know that as surgeons, but I don't know if the hospital administrators, insurance companies see that. I think that's going to be our challenge going forward as plastic surgeons, to define those differences clearly. I think studies like this are great. They give us this new avenue to start thinking about, but Dr. Rohrich, with all your years sort of leading things, at your hospital, I'm sure you had many meetings with the hospital about these types of issues, and how were you able to communicate to them differences in levels of care and surgeries? I mean, is that even possible?
Well, it is a conversation that we have a lot now, because it's always cost-based. They're saying, take it in the breast arena. Why are we doing free flaps versus tissue expander breast-based reconstructions? And of course, the more cost-effective ones are to do, expanders or immediate reconstruction with implants. But the quality of the results is not always the same. In fact, many times autologous is superior, and that's been shown in other studies. So, but I can tell you, long-term studies like this are going to be very important. If we evolve into a more nationalized healthcare system, because in the end, what really will matter will be cost over quality, and that's my greatest fear, because sometimes one does not equate to the other.
I will say, just to highlight a couple of things, the authors did note that, just having administrative claims, they weren't actually able to get granularity to really determine severity of clinical conditions, which may have influenced the treatment choices. But, they cite essentially all the main studies, all the meta-analysis, the Cochrane reviews that are all out there that have compared these groups. And each of those, I think, have their own set of pros and cons. It's apples to oranges, and in the sense that, certain patients of different ages, their functional status and their functional requirements may be radically different. And so, exactly, the outcomes end up being different, and what are you really looking at when you pull it all together? So I don't think it's all that straightforward.
No.
But there still hasn't been a real study that has shown, well, look, in these patients, this procedure creates a radically different or substantially better result across the board. So I think there's something there that we haven't really figured out as a field in hand surgery, what the ideal treatment modality is. And I think the authors are saying, well, if that's true, short of any, and there's new procedures that are always out there, the suspensionplasty, the implants that potentially could, hypothetically prove something different. Short of that, well, why not then, change our incentives, at least maybe balance them more, such that we are helping to reduce costs. I mean, $75 million a year, yes, in the overall budget of Medicare, which is, in the $400 billion, if not more now, certainly at the time when this is done, is probably a drop in the bucket overall. But it's not pocket change either. It's still somewhat substantial.
No, but I think the one thing that this does point out, and I think the hospitals are not going to like it, but they need to be rather than asking physicians to compromise care, we need to say, okay, the hospitals need to shift to more cost-effective facilities. It is clear that ambulatory surgery centers, not adjacent to hospitals, are far more cost-effective. That's where most of the cost savings is. And I think where Medicare could mandate saying, listen, if you're going to have your thumb CMC joint operated on. You need to have it in an outpatient ambulatory center. End of story. Unless, of course, you have significant medical illness. End of story.
Yeah.
That would change a lot, don't you think?
That cost, Dr. Rohrich, that cost went up 65% over the study period. I mean, forget inflation, 65% increase just by changing the setting, or just in a hospital setting. That's an insane number. Right?
Yeah.
So, Amanda, what do you think about this?
I mean, I completely agree. And Raj mentioned, it's interesting because they do in the study mention that clinically so far, at least the data that we have shows that these two surgeries may be comparable. But like Dr. Rohrich mentioned, there may be these little nuances that we haven't teased out in the literature yet. Why do so many hand surgeons prefer LRTI if the evidence shows that it's comparable? And then I think like what Raj was just saying, the fact that really a huge difference is the hospital setting versus the ambulatory setting. It's amazing what the price difference is.
Right.
So I think it's another very thought-provoking study from the University of Michigan. I think it has a lot of confounding factors, as Dr. Chung pointed out, and so did you, Raj. But I think it's a stepping stone to, is cost-effective care better care?
Right. Well, great. Well, we'll solve the healthcare budget crisis on the next edition of the PRS Journal Club. So everyone, stay tuned. Dr. Rohrich, thank you so much for awesome discussions and taking so much time out of your busy schedule to join us. We really appreciate it.
My pleasure. Well, it was fantastic. I learned a lot, and hopefully our readers will as well.
Yeah.
And our listeners.
Great.
Yes.
Great.
Thank you all. Take care.
Take care.